People boast, I just sleep for 4 hours. Your body needs that rest. Longer run makes a lot of difference.
Do you think lack of sleep causes heart attack?
As the Dalai Lama says, sleep is the best form of meditation. Why? Because it allows your body to reboot from inside.
Is stress related to hypertension?
Directly related. Especially in a city like Mumbai, where I practice, reason for blood pressure is stress. Higher the blood pressure over a long time will lead to higher coronary artery disease, will lead to higher incidence of strokes and kidney diseases.
So I want you to explain to us in terms of why high blood pressure can cause heart attack.
Diet, lifestyle has changed. Economic growth is there, but at the cost of everything.
You are saying that people are not taking blood pressure medications on a daily basis.
Only 30% come.
Why is the hesitancy?
Education. Because if we just control the blood pressure, diagnose it on a mass scale properly, treat it adequately, I'm sure 30% of your cardiac heart failure epidemic will go down.
What is the one thing that you wish your diabetic patient and listen and change?
Prevention. Pay attention to the diet from the 30s, early 40s.
If you're having blood pressure for a long time and taking blood pressure medications, if you are experiencing exertional shortness of breath, or when you are lying down at night and you're gasping for breath, all this is a sign of heart failure.
That's advanced heart failure. Easiest thing you can do, if you feel discomfort, even if it is ATP, get an EKG done. That's the easiest way to diagnose things.
I think even though it is a very bold statement, I think we can summarize this as any patient with diabetes, imagine that you have some kind of heart disease already. Welcome to another episode of our podcast series, Gut Feeling with Dr. Pal. In this episode, we have a very good friend of mine, Dr. Anup Taksande, a popular cardiologist in Mumbai. I brought him specifically to talk about how to diagnose heart disease, what are all the symptoms of heart attack. Before having an acute heart attack, what are all the symptoms that you can actually diagnose at a much earlier stage? How can you listen to your body to make an early diagnosis? And what are all the treatment options? We went deep into what is angioplasty, what is cardiac bypass, why is it indicated, is it safe, not safe, what are all the risk factors? We talked about diabetes management, hypertension management, family history of heart disease. We also talked in detail about cholesterol and lipid particles as well. This is one of the most comprehensive discussion that I ever had in terms of managing heart disease. If you or your family member has hypertension, has diabetes, or has high cholesterol, this episode would actually help you to understand what is the pathophysiology behind all these diseases so that you can make changes accordingly in your daily lifestyle. So the goal is you don't meet him in the hospital. We had a wonderful discussion. Let's dive deep into it. Dr. Anup, so happy to have you here.
Thank you so much.
So Dr. Anup is a popular cardiologist here in Mumbai. Very busy interventional cardiologist. And I'm so glad that your brother is my colleague and he's a nephrologist back in Chicago. So I'm going to extract as much knowledge out of you.
Yeah, sure.
So that I can learn and also teach my audience as well. So right off the bat, straight into the discussion, I'm going to give you a patient scenario. Okay, and I'm going to say, what will you do in this situation? Okay, I saw this patient in my clinic. This was before an endoscopy. Okay, so what happened? He was a 52-year-old gentleman. He had diabetes, hypertension, and everything. And the endoscopy was for epigastric pain here in the upper part of the stomach. So then I was talking to him, and then I said that, okay, so tell me when the pain is getting worse. And he says the pain gets worse whenever I climb stairs. And then I said, that doesn't sound like a stomach problem. So what happens? The pain gets worse after eating? No problem at all. Whenever I climb, the pain gets worse. And does it radiate anywhere? It radiates to the chest, left chest, and then it radiates down the arm. And then does it happen when you are at rest? He says no, only on exertion. Okay, so as you know, exertional chest pain or chest discomfort, I was so concerned. Okay. So then I referred him to cardiology, and then, they figured out that he has coronary artery disease. So if this patient comes to you, so I am a gastroenterologist, I refer to you. He has hypertension, he has diabetes. What is the test that you would do to diagnose any blockage in the heart?
I think so. It's an excellent scenario, excellent pickup by you, Dr. Paul. Whenever an elderly or middle-aged with risk factors like hypertension, diabetes, maybe dyslipidemia and family history, and especially if he's a smoker, this upper epigastric pain may not be gastric or the GI trouble, as you said, and as you rightly took on the history, and the exertional component and the pain, more than the pain, it's at times just the heaviness or a discomfort which exacerbates, which worsens by activity, by physical activity, is mostly anginal pain or related to the heart.
So decreased blood supply to the heart.
Yeah, during activity, what happens? Your blood flow is not commensurate to the requirement, and that's what precipitates anginal pain.
So during exertion, like climbing up the stairs, walking, running, you need more blood supply to the heart.
Yes, sir.
To support the activity.
Support the activity.
And because there is a blood clot,
stenosis,
decreasing the blood supply, that's where the pain is.
Yeah. At rest, the blood flow may just be adequate to perfuse and you don't have any symptoms. But during activity, the blood flow, the demand is increased. The demand is increased, the flow doesn't increase that much. That's the reason you get pain. It's a very classical symptom. Exertional component of that pain is a very classical discomfort.
In US, the most common presentation of chest pain is a person in the East Coast, like Detroit, Michigan, New York, New Jersey, where it is cold and they are snowing. In the morning, outside the house, the front yard will be filled with snow. So what they have to do, they need to mow the lawn or fluff the snow out. So while they are doing, they'll get chest pain.
I think it's a very classical scenario. Winters, vasoconstriction, physical activity, demanding physical activity, exacerbate.
In your practice, what is the most common situation over here?
The situation here, I think so. The classical chest pain, we obviously don't have the scenario as you described.
No snow, that's good.
No snow. But in Mumbai, I'm talking about the local city, one of the commonest pickup is usually when they have to change the platforms. You never know where the train comes, whether it is a platform 2 or 4, and they have to run over the bridge to catch or change the platform. And that's where they actually feel discomfort. They have to climb at least 2 or 3 flights of stairs fast. Very common scenario. I used to do it very normally. That's what the people say. Now it's becoming difficult. I have to stop in between. Very interesting. That's a pickup. That's something wrong. So someone who was well versed with a flight of stairs, doing it fast, not doing it. So I think so. In Mumbai, I think so. Everything is correlated with trains and traffic. So I think this train thing, climbing the flight of stairs is important. Yeah, I think. And as a GI person, again, talking to you, the gut, one point, very important point. Someone with a significant coronary artery disease, significant blockage, if they have a heavy meal, and postprandial, if they try to walk and get a lot of discomfort, minimal exertion leading to heavy pain after a heavy meal can be a symptom of significant coronary artery disease. It's a classical postprandial angina, which we call, it signifies extensive triple vessel or a left main, which is the most important artery disease. So,
I'm going to summarize what you said. So postprandial is after eating.
Minimal exertion leading to discomfort.
So the scenario that you are explaining is, let's say you go to a restaurant called A to B.
Yeah, all you can eat.
All you can eat.
Yes.
And then you eat everything like a full-blown lunch buffet. Yeah. And then you are walking from from your hotel, from the restaurant to the car in the parking lot, and you had pain, or even just stomach discomfort, little bit.
It could be. And if it's repetitive, means that is actually repeated again and again. I think so. First thing, go and consult, because that may reveal something nasty.
any age group that we should be concerned about, or doesn't matter?
In India, I think so. I have treated as young as 18 and 20 years here in. So 20 years I have done a primary angioplasty to open up the choked vessels. So no age is barred.
So no age is barred.
No age is barred. That's
Usually it's an elderly disease.
Elderly disease.
55, 60.
60. But in India.
In India.
As
I would say Indian community.
Indian community. Indian Southeast Asians, you can
South
say.
Asians,
You can just mention the Southeast Asian community. We as a community have early onset of coronary artery disease. What the classic literature would say is like 10 years earlier. I think so, more nastier, more diffuse, more extensive. A lot of things. So the Indian genetics are such that we are more prone for coronary artery disease. We already have the dubious distinction of being the diabetes capital of the world now. So
you'll be seeing a lot.
I see a lot.
So when a patient comes to OPD, okay, and then says, hey, I have chest pain. People think that, okay, people know about stress testing. Okay, stress testing. Can you explain how a stress testing is done?
Right. So I think for patients who come to the OPD with classical or atypical presentations, obviously when they come with an atypical or some chest pain or some discomfort, we need to work it out. So the certain battery of tests are advised. We look at the probability. Before ordering a treadmill, it's all about probability. We look at the probability, whether he is in low risk for coronary artery disease, intermediate or high risk. And accordingly, our treadmill is as well advised, but it is advised for, apart from the ECG, 2D echo. We actually try to do a 2D echo or 2D echocardiogram to assess the heart functioning, the valves.
Okay.
Anything.
So you get an ECG.
ECG.
Okay. ECG is the electrodes that they keep on the heart. And then you can look at the arrhythmia.
Yes.
And I remember with whatever cardiology I know, there are some signs that you can pick up. That there is decreased blood supply to the heart. The second is the echocardiogram is what is you have a gel applied on the heart.
And looking into
you have a small probe goes there, and then you can actually see the heart beating.
And look at, it's very important. You should not miss out on valvular diseases. You should not miss on obvious at rest. If there is some problem, we don't order a treadmill. So when the ECG and 2D echo is fine, let's say third test we usually do is a treadmill test. CST or computerized stress test, what is called.
So when people say stress test and everything, you are stressing your heart by giving more work to your heart. How are you giving them more work? By running on a treadmill.
Running on a treadmill, exactly.
If you don't run on your treadmill every day, you'll run on this treadmill.
Exactly. So running on that treadmill gives us an idea about any ECG changes which are happening, number one. We look at the physical, parameters like how the blood pressure is rising. Ideally, it should rise, it should not drop. And number three, the symptoms. Whether you are experiencing the same symptoms on the treadmill that you are experiencing before. So three important things. The technician along with the doctor is always there to look for any kind of an abnormal ECG sign.
ECG is fine. And they run fast.
They run fast. Though there are stages, obviously, with stage 1 with minimal inclination, minimal speed, and then the stage 2, and then stage 3 and stage 4. We usually try to look at the metabolic equivalents. We try to look at the targeted heart rate. So there's a formula set for it. So if you achieve a target heart rate without any ECG changes, without any discomfort, and able to complete the test, metabolic equivalence required, I think so you are good. But there are ECG changes, and the same pain that you experienced is experienced while doing the treadmill along with ECG changes. It calls for an angiography.
Okay. I'm going to summarize that. Okay. So the patient had chest pain. It comes to you. There is ECG, relatively normal, echocardiogram, which is a picture of the heart, normal. You do a stress test where the patient runs on a treadmill. On the treadmill, you slowly increase the difficulty by inclination, speed. While you're doing that, if you experience the same chest pain, what you had to that you came with, which means that it is a decreased blood supply to the heart. So we need to find out where the blood supply is being blocked.
So
For that, we do something called
angiography. Coronary angiography.
Coronary angiography. Okay.
That would be the next test that would be advised. However, at times, again, as I told, it's more of a probability testing.
Yes.
Right? So what we find in clinical practice, it's important. There are false positives. It's a screening test again. It's a probability test. So you can have false positives, you can have false negatives, you can true positives and true negatives. So in Indian, especially females, the treadmill gives a very positive impression. A lot of ECG changes. That's what I have seen over last 17, 18 years. A lot of the females, especially 50s, 55s, false positives. Meaning there are a lot of ECG changes even on the treadmill. When you do an angiogram, it's clean. It's clean. So then again, there are false positives. But since the ECG changes are there, which beyond the arteries are the capillaries, and then there's the endothelium. So we actually look at the capillary level and the endothelial dysfunction in this patient. So possibly normal epicardial arteries. So the angiogram is clean, but we don't know what happens at the capillary level. The perfusion is less. The relaxation is not so great. ECG changes are there. But yes.
So we'll track back a little bit, just coming back to the angioplasty. So I'm going to tell you what I understand, and so that in a layman term. So the idea is to see how many blockages are in the heart. So there are 3 major blood vessels.
Yes.
Correct? What are they?
The left system, we have the left main.
Left main.
And it bifurcates into the left anterior descending artery.
Yes. We call that as LAD.
Is the terminology is like the widower's artery because it's so big and it supplies almost 50% of the blood vessel.
Thankfully, you brought the important point. It's called widowmaker. Widowmaker. Because this is the only main artery that supplies the entire heart, and it can get blocked. And if it gets blocked, the entire heart circulation can be compromised, so leading to a death of the person. Then that is why it's called widowmaker.
Widowmaker artery. So left main, LAD, then you have the small branch coming after the LAD is like the circumflex, left circumflex. Again, it's a main artery. Then the right side we have a single artery, which is called the right coronary artery. Most of the blood supply to the electrical system is through the right coronary artery.
Yes. And
And
then posterior.
Yes, it goes right.
Goes on the back.
Backside. Just grooves around.
Okay. So there are 4 chambers, 2 on the top, 2 on the bottom. And there are 3 major blood vessels that people should remember: left, right, and the posterior. So while you're doing the angiogram, it's through the groin area.
Groin or the radial.
Radial.
There's wrist.
Through the arm.
Wrist.
So through the arm or the groin, you go all the way into the heart. You inject a dye, and you see these 3 blood vessels. It's absolutely amazing. Absolutely amazing. You inject a dye, and it will fill up the blood vessel, and it will tell you which of the blood vessels are blocked and how many percentage.
Exactly. So again, when you advise an angiogram, it's done on a daycare basis mostly. Daycare. So through the wrist, it's pretty comfortable for the patient, so they can walk out. If it's fine, maybe after 3 to 4 hours, like in a radial lounge or nicely in a cafeteria, have a cup of coffee and they're off.
They can go back on the same day.
Yeah, after 3 to 4 hours. So angiography typically is very, very minimally invasive, extremely low risk, in good hands, and it reveals. And the most important thing is it reveals the exact nature of the disease, exact percentage, and it gives you a plan. What would you be advising? Whether it's
So people should not be afraid of angiogram.
Absolutely not. Right. When it is advised in a proper scientific evidence-based way, I think so they should not be. And if it's advised, most of the cardiologists would be advising to know the anatomy well. And obviously, if it's, what you can say, very difficult to gauge it, but maybe around 50%, 60%, something which can be managed with medical management, lifestyle, dietary. I think so aggressive management is advised. It's not necessarily that you find something 40, 50, you just stent it or send for. No. Unless it's significant obstruction, which causes pressure drop and it's correlating with the ECG territory, nobody would actually advise angioplasty, putting in a stent or a bypass.
Yes, of course. So when you inject the dye, you look into all the blood vessels. You can see how many percentage of the blood vessel
Yes.
is blocked. Usually, when you do urgently, 100% is blocked. Then you put a small stent.
Right. So that procedure is called as primary angioplasty in myocardial infarction. It's called as PAMI. So it's offered for patients who have a major heart attack. What is a major heart attack? When the artery is 100% chopped off. No blood flow. No blood flow. The myocardial muscles or the heart muscles are deprived of the blood flow, oxygenation, and they are dying every second, every minute. Here, time is muscle. The earlier you open up the artery, put in a stent, ensure that the flow is well established, the better the functioning of the heart in the longer run. Right? So the terminology, time is muscle, it stands true for major heart attacks. Extremely important. Here is green corridor is established in the hospital. Any hospital has a program, like a codes are announced. If you have a major heart attack, they are straight away wheeled into the cath lab. Angiography is done to determine where the block is. Wire is crossed. Maybe if there's a blood clot, we try to retract the blood clot, do a balloon, and possibly, if needed, we put in a stent, which is there in most of the cases. Put in a stent. It will ensure that
the blood supply is back.
Yeah, so
Wow.
it will ensure that the life is saved.
Wow.
Most
Let
important.
me just rephrase what you said, so like a summary. So the patient that I told you is an outpatient, right? So he had chest pain, and then we had time at that time, right? We're not talking about in hours, we're talking about in weeks. So came, stress test, we did angio, there's a small block, 70%, 80%, then you put a stent in, and then you go. The situation that you are explaining is a patient comes with severe chest pain. Severe chest pain that the patient cannot wait. Come to the hospital. Time is muscle. Muscle is the heart muscle. If you delay the timing to the stenting, every second you're losing the muscle.
Heart muscle.
Heart muscle.
Which is
And
long-term
once
process.
lost,
they don't.
once lost, they don't come back.
Yeah. So golden hour is something like 60 to 90 minutes.
60 to 90 minutes.
is the golden hour.
Once the patient have chest pain, they need to open up within 90 minutes. Open up, which means the patient gets transferred from the home to the hospital, cath lab. That's why all the cardiologists cannot stay beyond 15 minutes from the hospital.
Yes, they have to be rushing in. Yeah, and someone has to stay in the hospital to do it as urgently as possible. But that's for an urgent situation. At the kind of situation that we had, we have time. Do an angio, decide what we need to do, and then decide.
Yes. Beautiful. While we are in that situation, I also want to touch base upon bypass surgery. People confuse between angioplasty and bypass. Angioplasty is when one blood vessel is blocked, you put a stent in, good. But bypass is when all the three blood vessels are blocked.
Right. So I think so again goes on to say, when on angiogram you determine, yes, all the three vessels are there, they're diffuse, at times very calcific. They're very calcific, hard, long segment, which may possibly not be yielding well with balloons and stents. Then obviously you should always think about whenever the left main is blocked or at the bifurcation, or a previous stent has blocked, then again calls for bypass.
It's a very important point is if you have placed a stent, if you don't correct your lifestyle, the stent can be blocked again.
Yes, it can.
Instant thrombosis.
Instant, we call restenosis. So it's like development of that blockage or atherosclerotic plaque within the stent. It's called. So then it calls for a more aggressive action, at times bypass. Bypass involves opening up the chest, using the internal mammary arteries, the natural arteries to bypass the blockages.
It's very important. I want your opinion on this. So I'm just summarizing so audience can understand. So the case that we're discussing is we have multiple blockage. So you put a stent in, it's not going to work.
Yeah, multiple. I think so. There are different scoring system against. It necessarily doesn't. We have patients with 5 or 6 stents also, but there's something called as syntax scoring. So we look at the probability again. What will be better in the 5 years? Whether multivessel angioplasty or in bypass would be better. That's a scientific scoring which is called as syntax scoring.
Syntax. So basically, bypass is what? Similar to a bypass road. Bypass road, what does it mean? You are traveling in a straight road. If it is blocked, you bypass, right? So this is a blood vessel right here. There is a block. You cannot put a stent because it's pretty severe and calcified. So you are taking another blood vessel and putting it as a bypass so that the blood is coming over here, will not go over here. It bypasses and comes over here.
Yeah. It is fantastic surgery. Life saving.
Life saving.
Yeah.
It's an open heart surgery.
Open heart, yeah. It is.
I have assisted one.
Yeah.
Wow. Only then I realized that I will not do cardiology.
Cardiac surgery, maybe. Cardiology
No, it's for people who, like you, who are really into it. For me, stomach, colon. And it's a long surgery, right? 6 hours, 8 hours.
Bypass surgery would involve approximately maybe from opening up the sternum, doing the grafts, closing it back. I think so 4 hours approximately.
4 hours, yeah. So that's what they call bypass surgery. And it's a good prognosis, right?
Yeah. So especially for diabetic patients, especially for coronary artery disease, which is diffuse, extensive, multivessel, I think bypass would be better in the longer run. Yeah, we are not looking at very short term. In the longer run, 10 years, 15 years down the line, how our grafts are working vis-a-vis the stents, then maybe a certain subset, they do well with the bypass. Yeah.
I had a 40-year-old guy, patient. I was involved as a gastroenterologist standpoint because he has started having some ulcers in the stomach. Cardiologist recommended bypass because of triple vessel disease.
Yes.
Triple vessel is you have disease in all the three major blood vessels.
Yes.
And he's from Bangalore.
Bangalore.
He was Bangalore, but he's living in Bay Area. So he said he called me and then he said, Dr. Pal, can I ask you a question? I'm so scared. I don't want to do the surgery. What the option I have? I said, you don't have an option. Right? What are the options you have? You don't have an option. This is a very safe surgery. Yeah, with good hands. This is a wonderful prognosis. You're only 40 years old. Yeah, you should don't take a second opinion. He was asking me, if I drink turmeric water, it will go away. I said, no, turmeric water, if you drink, only the water will go away.
No, I think like people are scared. That's first thing to be realized. Realization is not there that I have so much of life-threatening problems. So a positive approach, making them understand that this would be beneficial in the longer run is very, very important. It's good for your lifestyle as well. So that's important. Longevity is a part, but lifestyle also, because what possibly is restricting you from doing things which you can will be possible after a bypass surgery. So people run marathons after doing bypass.
Wow, people run a marathon. I will tell you an exactly opposite scenario. This was 48-year-old and they recommended stenting. Okay, this was in India actually, I think in Madurai. Okay, so they called me for a second opinion in California. Okay, so I said, I looked up the report, I sent it to my cardiology friend, and he said, dude, it's pretty advanced and we have to get either bypass or stenting. He was even concerned about angioplasty. True story, you will not believe it. By the time I conveyed the message to him, he had a massive heart attack.
He had to be operated urgently.
Operated urgently?
Urgently, yes.
Operated urgently. So urgent bypass also people do?
At times, yes. Needed.
But at that time, it'll always better to do it on an elective basis.
Elective basis is always good. Yeah, everything in place. I think so that is comfortable for the patient, the relations, and the doctor as well. Bypass is something, elective is better. Urgent angioplasty, guys like me, at the mid of the night.
Middle of the night.
Yeah, but bypass surgery, I think so elective is better.
But that is so rewarding for you that you save a patient life.
Yeah, I think so.
Rather than your wife might not like you.
Yes.
Because you have to go up in the middle of the night.
Middle of the night.
But patient coming with chest pain, you do the angio, 100% blockage, you put a stent, blood flows in, you know you save the patient. If not, the patient is going to die. Yeah.
Yesterday we did 2 of them and both are doing well. So,
Have you seen patient die on the table?
yes.
Yes.
Extensive disease. So
That you cannot, no matter how the stenting is
yeah,
done.
it's, what they say is anatomy. We are looking at anatomy here. Artery is blocked. We open up the artery, put in a stent. But if the patient comes in a cardiogenic shock, pulmonary edema, pulse BP is almost
no blood pressure at all.
No blood pressure at all. We put in whatever life-saving measures. We put in intra-aortic balloon at times, impeller, ECMO at times. But still, patients have refractory shock and happens.
So I always say this, even how advanced medically, there are so many technological advances in multiple medical fields, still prevention
is always the golden rule. It's always the golden rule. Yeah.
There is always this percentage of patients, we can't do anything. We can't do anything. And we have seen people die on the table.
It is a true story.
True. So the reason that we spend so much time in explaining all this is to explain to the audience that we don't want to be in a situation. Because treatment options, even though it's good, there could be situations where it might not work. So it is absolutely critical to prevent for this complete blood clot to happen. So coming back to my patient, he has hypertension and diabetes, and you said a very important risk factor. I don't think many people understood. Family history. Correct? Can you explain that about?
Wow. So family history is such an important determinant, how aggressively you should be treating the patient from the doctor point of view. And as a patient, how aggressively you should control your lifestyle, diet, physical activity, including, and how aggressively you should be keeping a tab on your health status. Important. Family history, one or both the parents having coronary artery disease, your genetics are at play.
Risk. So if you have heart disease, or a heart attack history or heart disease in your father,
early
early
heart attacks. So maybe 70s, 80s, it's still,
it's okay.
It's not okay in the sense,
fine.
But early
means you'll say
around 45, 50.
So if your father had a heart attack or heart disease around 45, then you are at an increased risk.
Yes, you are. So the genetics are there.
If your mother also had, the risk doubles.
So the family history is there. I think so genetics have a role.
How about grandfather? Not that much, right? It's only first degree.
I think so. Because I think so our grandfathers and the grandparents were blessed a lot because coronary artery disease was somehow...
You know why? Because they slept very well.
The peaceful life. Yeah. They slept well, ate well, more relaxed. Lesser, lesser means to do things, but lesser expectations.
Correct.
So they were more peaceful.
More peaceful.
Yeah.
More peaceful.
Yeah.
So family history. Wow. So the take home point is, if you have a family history of heart disease in your mother or father, you better consider that as a wake-up call. If you are from an Indian community or a South Asian community, that's even more important.
Extremely important. In Southeast Asians, the whole community, the dietary patterns, the family history apart, we have that, I think so. We can't talk about it, but the Indian paradox, the thin Indian paradox.
Yes, of course. Of course. We'll talk about that in detail though. So coming back to the patient, where we talked about hypertension, diabetes, and the family history. So this patient had hypertension. Okay. This patient, I vividly remember because he moved from a gastroenterology specialty to cardiology. Because he was supposed to get gastroenterology workup. So I figured out that, okay, this is not gastroenterology, go to cardiology. So he had hypertension. He was taking metoprolol, beta blocker for hypertension and some diuretic for hypertension. His blood pressure was around 135, 36, even at home or normally, okay. At that time, it was very high. So I want you to explain to us, educate us, in terms of why high blood pressure can cause heart attack.
I think so. High blood pressure. There would be certain now the guidelines keep on changing and there's a lot of confusion everywhere. What is a high blood pressure?
Yes.
So
Oh, no,
elderly.
let me take the question back. I'm going to say, what is high blood pressure?
Yeah.
What are the numbers?
Right. So it's again, first of all, the blood pressure is a very dynamic thing. Yeah. So in the office, if I record a blood pressure, it would be different completely from what you recorded at home. So it's the white coat hypertension. So how much to rely? I, as a cardiologist, when I have to label, it becomes in Indian setting, it's like an pattar ki lakir, or it is a final statement. So I better be sure he has proper blood pressure.
So the thing that you're talking about, white coat hypertension, is, just for the audience, is that your blood pressure will be 120 or 80 normal at home.
Right.
You come,
Get
you
stressed
see
out.
Dr. Anup, blood pressure goes up.
Up. So that's white coat. Possibly. So you don't treat it based on one reading of that. Important. So I advise for youngsters especially something like an ambulatory blood pressure. I do advise it quite often, 24 hours charting of your blood pressure to know the peaks and troughs throughout the day, during activity, at night time. Very important. Right. So that activity, the blood pressure measurement at night, the dipping of blood pressure at night is extremely important. Young patients, especially stressed out, type 8 personality kinds, the non-dipping parameter in blood pressure is extremely important.
So you're saying that ideally, normally, blood pressure should fall at night because, things are
it's extremely important.
Things are taken. But you're saying that in non-dipping means if it is still high at night.
High, yeah. It's one of the earliest catch that you should treat. Very important. So early morning surge, you can maybe you have heard stories of patients having heart disease more in the early morning. So that early morning surge of blood pressure is extremely important again. So that's the reason nowadays most of the scholarly papers are coming up that you should target, take your pill at night to maintain that lowering of the nocturnal pressures and prevent that morning surge. Important. First thing first. So I think so when we talk about the first office reading, it could be white coat to an ambulatory. I do it for young patients before labeling them as hypertension.
So I'm just asking some questions to reassure this. A patient comes to your office, blood pressure is 140 over 90. You don't label hypertension because it is only one time reading. So you ask the patient to go back home, get a blood pressure monitor.
I think so. We can
from
do
a pharmacy
that
store.
Yeah.
And then measure blood pressure.
You can do the home blood pressure. That's the home blood pressure monitoring. So you can do it with your own instrument, maybe 6 to 10 a.m. in the morning, 6 to 8, fixed times, whatever you can do, 2 readings. Or you have a device, 24 hours ambulatory BP it's called. It's a device which is given at outpatient from the hospital and that will continuously record your blood pressure.
Is it right?
Yeah.
So the blood pressure cuff will be attached.
And you have a machine which you
carry. You have a machine that you carry for 24 hours.
Yes. And then we look at the peaks and troughs. So that gives you a better idea. Yeah. So now once we are sure that the blood pressure is there, right?
Yes.
So once we know the blood pressure is say 140 by 90, the mean blood pressure is high, the nocturnal blood pressure doesn't dip much. You have an early morning surge and you think this patient will benefit. So how does it translate into heart attack? Is higher the blood pressure. All the studies over last 30-40 years, and there have been like a lot of multiple studies, higher the blood pressure over a long time will lead to higher coronary artery disease, will lead to higher incidence of strokes and kidney diseases and peripheral vascular disease. Why? Because the stress and the strain of the high blood pressure, the shear stress and the force of the high blood pressure inside the vessels causes a lot of wear and tear in the endothelium. Yeah, that injury will lead to plaque buildup slowly, gradually. So it leads, apart from the other factors, obviously diabetes.
Wonderful point. Yeah. I'm just going to re-summarize it. So there's a blood vessel. Yeah. And the lining of the blood vessel is called endothelium. Okay, it's a small cells that is lining inside. This endothelium is extremely important to make sure there is no clots are being formed inside the blood vessel. When we say high blood pressure, what is actually happening is this blood vessel wall is getting thickened.
Continuous hammering. inside, and it will become thickened over a period of time, and then the endothelium will also become more dysfunctional. It won't relax, it becomes more stiff, and it will develop plaques.
And endothelium stops working, starts forming small clots. That's the starting.
That is the whole thing. So the higher the pressures and the longer the duration of the blood pressure, higher your chances of having stenosis, narrowing of the blood vessels in the longer run.
You know, this patient, 52-year-old, he got diagnosed with blood pressure at 43. So the longer, 9 years.
It's very imperative that you control your blood pressure. In fact, there have been studies, beautiful studies in the literature. The blood pressure is controlled, less than 130 by 80, your chances of having all these things, the end organ damage is what you call, is less.
So if you can decrease your blood pressure, the likelihood of blood clot formation, everything is low, which in turn there is decrease in heart attack.
So in Indian setting, I think so. This is very interesting statistics. What we see, I'm talking about Indian because Indian patients I see. What we see, hypertension is such an, I think so, very common in the sense, very, very enigmatic, I will say. Why? First of all, it is a silent killer. It's called as a silent killer for a reason, I will tell you. What we see in the OPD practice or in the clinical practice is really the tip of the iceberg. In Indian mentality is such. So maybe out of 100 patients who are hypertensive in the community, only probably 30% are diagnosed.
The remaining 70 are undiagnosed.
30% are diagnosed. They are prescribed medications. Approximately only 30% take medications. Out of the 30%, because they don't want the taboo of taking medication. So it's a wrong notion. If there's something myth that you want to burst, you take medications for good long-term benefit. So out of the 30%, only 30% take medications. And out of the 30% who are taking medications, only 30% have adequate
control. So if you calculate the numbers, out of 100 patients, only 3 patients have adequate control. Probability.
In the whole
community.
It's such a vivid number, and that's the reason, we focus a lot on so many things like diabetes is, I guess, high cholesterol. There's a lot of noise, about, but blood pressure is somehow
not being talked about that much.
Not talked about. And I think so it's an important, almost a silent killer is the right term. And we have to be, as a clinician, our job is not only diagnose, but to educate.
So you're telling me that high blood pressure can actually kill you?
100%. 100%. And that is such an important thing. Because if we just control the blood pressure, I will tell you, and diagnose it on a mass scale properly and treat it adequately, I'm sure 30% of your cardiac heart failure epidemic will go down. It's actually mass scale programs are needed. So as a clinician, as a doctor, diagnosing is important. Educating is equally important.
In your practice, you are saying that people are not taking blood pressure medications on daily basis.
Few come. Only 30%
Only
come.
Few people.
And then,
why is the hesitancy?
Education, I think so. Because it doesn't produce important. It's like, there are two things. First of all, high blood pressure, they don't produce symptoms. Number one, 180, 190, oh, I'm okay with that. No symptoms. Silent. Number two, they don't want to be labeled as hypertensive.
Oh, they don't want to be labeled as you are hypertensive.
They don't want to be labeled as someone with high blood pressure. Number three, I say like bravado. Nothing happens to me. So 3 things: education, false bravado, and maybe misconceptions. Everything plays a role. So I think so that needs to be focused. And if you actually do something on a mass scale, the epidemic of both the heart diseases, coronary artery disease, and the heart failure will go down drastically. We don't care about blood pressure as much as the diabetes and cholesterol. With a lot of noise.
Lot of noise. You said that you had a patient with 20-year-old
Yes.
heart attack, right?
Yeah. But
I have seen multiple people like that as well. Very common in Indian community, no matter where they live, in India or outside India, doesn't matter. So in that situation, people say that, stress is one of the main thing, correct? Is stress is related to hypertension?
wow, I think so. It's something that I focus on a lot. Yeah. It's directly related.
Directly related.
Especially in a city like Mumbai, where I practice, number one killer is stress. Number one killer for reason for blood pressure is stress. Commuting, meeting targets, the kind of lifestyle that we have, the kind of food that we have, maintaining life, professional life, personal life balance, work life balance, everything adds up to the stress. Less sleep, everything. And again, a forgotten cousin, you see, stress relief comes when you talk about prevention of heart disease. That's something in the subtext is written stress management.
At the bottom.
At the bottom would be stress management.
It has to be at the top.
I think so. Lifestyle should include stress management.
Going back, just wanted to put everything together. Okay. So a 20-year-old, 25-year-old software engineer or any other professional, very busy, wanting to get advanced in the career, because he's stressed out, there is increased cortisol, increased adrenaline, sympathetic stimulation. And your blood pressure, your blood vessel needs to support you with increased blood supply. So slowly blood pressure kicks in. And then after that, it gives a strain to the heart, clots form. Boom.
So for a young patient, it's mostly multiple factors. Stress is one important thing. If it's smoking is most important in young patients, not only in males, but I think so it has taken up in females in a big way.
So smoking can cause heart attack in women earlier.
So smoking, I think so, if there's one risk factor you have to take away from young patients, quit smoking. Quit passive smoking as well.
Tell me more about passive smoking.
So passive smoking, when you are in actually a group and you are actually wanted to be part of the group, obviously the peer pressure, a lot of smoking, a lot of intoxicants. So the sympathetic surge happens. The vessel becomes more sticky and more vulnerable. And especially if you have a genetic predisposition, you should stay away. Because that smoking, genetics, diet, not a good
combination. So passive smoking is somebody else smoking in the house
or in a group. But if you are in that crowded place, enclosed space, a lot of smoking.
I flew into Mumbai. In Mumbai airport, there's a smoking lounge. It's wonderful, beautiful. It was written smoking lounge, and people were inside smoking, and other people were outside. The only problem was the door was open.
So I think that calls for a strict attention, yeah.
So that's exactly what we're talking about, enclosed space. But it's not like one-time thing, right?
It continues.
Chronic.
But if you're a chronic smoker, I think so. One risk factor that you should always stress upon: quit smoking. That's the number one. Young patients, yes, you manage your blood pressure, stress, everything, but smoking is something that you should, and there's no qualms about it. There are no second thoughts about it. Just quit it. The best day is today to quit smoking. I think so. Limit your alcohol. I know it's definitely difficult to.
So alcohol can cause heart attack?
Not directly, but again as a part, it's advisable. Now the recent guidelines would say, as a gastroenterologist also, no alcohol. I think so. That is the Indian guidelines right now. Previously it was something was permissible.
Yes. Previously it was 12 ounces of beer.
Yeah.
5 ounces of wine,
right,
and then 1.5 ounces of hard liquor.
Which translated to maybe around 60 ml or something of hard liquor.
Yes. 1.5 is 45 ml.
45 ml.
Of whiskey, vodka, or anything like that. And then 5 ounces, 150 ml of wine. And then 12 ounces, it's a 1 can beer. I'll tell you how that came out. In Western literature, there was a study that just said, okay, beyond this limit, there is no major outcome. Within this limit, there's no major outcome. But what they are missing is, within this limit on an everyday basis.
Yeah. And nobody stops at that.
Correct.
That's what.
I told my patient once, you can drink only 45 ml of vodka. And then for that, I will drink water. He says, that nothing.
I'll stop drinking.
There is
So
no buzz in it.
that's what happens. Like, nobody stops at that single drink. So the Indian guidelines have stringently said this time, I think so. The Indian guidelines, no alcohol is safe. So they stop. Quit smoking is important, but yes, whatever it is, you either stop it completely at the alcohol part or limit it.
In your practice, we're talking about hypertension. Multiple studies have shown that physical activity, exercise decreases the blood pressure and everything, right? You see a lot of patients with hypertension. Of course, you recommend physical activity. How many people actually do?
Oh, now that's interesting. It's very difficult to put it in percentage, but yes, the youngsters, maybe up to the early 50s as well. They take up pretty seriously the physical activity, at least in any form that they want. Brisk walking to reduce their weight, the BMI. I think so. It's percentage wise, maybe I say 3 out of 10 would be a good number. Who actually not everyone
Who actually will complain?
will be compliant with. They will be motivated. Ultimately, it's self motivation. No matter how much you educate them, it has to come from inside. So
The remaining 70%.
they're happy taking drugs, medications.
See, that's the key. That is what I was getting at. I went to my native village and I met my Periyappa. Periyappa is an uncle. And then he said, "Pal, come here. Look at all these medications. Am I taking it right?" And then I said, "Uncle, this dosage is 20 milligrams. If you walk every day, the dosage will decrease maybe to 50 milligrams." Right. And then he says, "Who will walk, man? Huh? I'll take 25 milligrams."
Taking it is easy, right? But yes, reducing weight, physical activity, whatever the ACC guidelines, the American College of Cardiology or the WHO guidelines would say, at least 5 to 7 times a week, or 5 to 7 days a week, you should have 20 minutes.
Correct, 20 to 30 minutes per day. Yes.
That's
yes.
the
basic minimum.
So you can do more than that. So that's known to be helpful. It's not only reducing the weight, but physical conditioning, both mental conditioning as well. They get motivated to do more. I think so. It's equally important. They start following their diet well. So I think so. That's part and parcel. Yeah.
One more thing I wanted to touch upon while we are on the subject of hypertension is you talked about high blood pressure, endothelial dysfunction, and blood clot formation. Okay, and we talked about the angioplasty, stenting, and everything. The other complication of high blood pressure is chronic stress to the blood vessel.
Right.
And the blood vessel is coming from the heart.
Right.
So the heart keeps on pumping to a point that the heart gets thickened.
The hypertrophy happens.
Hypertrophy.
Right.
And eventually it'll give up.
Yeah.
And is that what heart failure is?
Yeah, the heart failure again encompasses a lot of things. But yes, any chronic stress over a long period of time, it's like flogging your horse. At some point of time, it's bound to stop and fall. So the heart also has a huge capacity to work continuously take up the stress. It has its own mechanism by which the heart muscles gets thickened, hypertrophied to help it pump more. Yeah, but after a certain period of time, obviously the energy dynamics or the muscle dynamics won't allow it to pump as much as is needed against the increased pressure. So it starts failing. That's important again. That would be again like missing the boat. We want to act even much before that, but that would be the earliest signs and symptoms when the patient comes in the clinic.
What is the most common symptom of a heart failure?
Breathlessness, called as dyspnea. Shortness of breath, breathlessness. So breathlessness there are different classifications, but yes, whatever you are able to do, before. Like I gave you the example of walking up the flight of stairs for catching the train. You are able to do it well and you are feeling breathless now. So anything which is limiting you, I think so that needs to be the first trigger which you should be taking to the clinic. When you actually experience breathlessness even during normal activities, I think so you've missed the boat by a long margin. So I think so earliest detection, earliest realization is very important. And I think so paying attention to the symptoms and your own body, hearing to your own body is very important.
So tell me whether the statement is right. If you're having blood pressure for a long time and taking blood pressure medications, if you are experiencing exertional shortness of breath, or when you are lying down at night
Yes.
and you're gasping for breath,
I think so. Yeah.
all this is a sign of heart failure.
Yes, that's advanced heart failure. Yeah. You don't want to act that time. You want to act much before that.
Much before that.
Yes, advanced heart failure. It's probably if you're getting symptoms at rest while sleeping, getting up in the middle of the night, going to the window, gasping for breath. That's the classical scenario. So that's, I think so, pretty much advanced.
So we need to catch much early. If you have a patient with hypertension, how often that patient should come and see you?
If it's well controlled, maybe 6 months. 6 months visit is okay with the blood test, whatever the battery of tests which are advised. Apart from the blood pressure, obviously we would be advising for the diabetes or the lipids and inflammatory markers and so many things. And hopefully...
So once every 6 months?
Every 6 months is fine.
How about salt restriction?
Wow, I think so. Salt again is such a difficult thing to explain to my patient. So Indian mentality is of extremes.
Let me rephrase the question. I'm going to say that we know that salt increases the blood pressure.
Blood pressure, yes.
How do we control it?
Right. So that's what. Ours is a mentality of extremes. Indian mentality. I advise someone to restrict. What happens next? 2 weeks later, the elderly gentleman comes in an almost falling state because the family starts cooking without any salt. Right. That's a very funny but common scenario. We do extreme. If we want to do salt, we do pickles, papads, everything with full salt. Salt restriction, no salt. They actually go bland diet for a long time. I don't know. Sodium level drops, and along with the medications like diuretics and all, it tends to fall even more. And they come with hyponatremia. So I think so. Salt restriction. I think so. The golden rule is something 1.5.
1500 milligrams to 2000 milligrams per day.
So. That translates to what you can say, a teaspoon of total salt per day. That's approximately for a person. Approximately. So
it's not only the salt that they are using, it's the sodium content of the other food as well. More important, I'll tell you the most common mistake that patients do in any patient with blood pressure is they think that salt restriction means only the table salt they are adding to the food. That is not the case. The French fries that you're eating, the packet chips that you're getting, everything has sodium. So if you have blood pressure, turn the back of the packet, look at how much sodium it is. It should be less than 2000 milligrams for the whole day.
Any packaged stuff, any processed stuff, any fermented stuff, lot of salt. Simple. Indian pickle, papads, everything.
Papad. One of the most common item that is very rich in sodium is fried rice.
It is. The Chinese
fried
rice. A lot of it's added. High in MSGs and a lot of salt.
I had a patient while I was in medical rotation. In the morning, he came in with shortness of breath and then pedal edema, swelling of the legs. And I know that he has hypertension. He went into heart failure. I just saw him like a month ago. I said, dude, I told you not to take anything more than 2000 milligrams of sodium. And he said, I didn't take anything. And then I saw a small polythene bag right next to him. You know what it says? Asian Chinese restaurant.
Yeah.
And he has the remaining fried rice to go box inside.
That's what. So I think so. Rather than look at so many things, again call for a dash. What you can say?
Dash.
Dash.
What is dash diet?
the dietary for salt restriction.
Exactly.
So
It's a DASH diet for hypertension.
dash data. So I think so that's inculcates not only restricting your salt content, but there is a lot of emphasis on fresh vegetables, whole legumes, fresh fruit. The dietary source needs to be uh, properly verified and taken mindfully. I think so. Again, mindfulness in eating is extremely important. Be very sure what you are putting inside to be peaceful. So I think it inculcates legumes, nuts, and so many things to be sure about what you are eating. Dash diet included, yeah.
Super. Beautiful. So we talked a lot about high blood pressure. The same patient also had diabetes. Okay. And if you look at my channel, I'm not sure whether you know, I have a social media
I
channel.
know. Everyone is well aware. You're so popular.
So my mom still thinks that she's asking me, "You're still practicing, right?"
That's a typical Indian mom's question.
You leave the doctor.
You can't.
So that patient has diabetes. In my channel, what we all talk about lots of diabetes and everything. But one thing I've not talked about is why are we really focused upon decreasing your glucose, all this thing is diabetes can kill you by causing heart attack. How does diabetes cause heart disease?
Yeah. So diabetes is such an you can say multifactorial again illness which impacts right from head to toe every system. It's considered as an coronary artery disease risk equivalent. Once you have been labeled as a diabetes, your parameters, your set goals are different from non-diabetics. Your level of LDL cholesterol, blood pressure, everything, the targets are different. That's the reason diabetes is called as a coronary artery disease risk equivalent.
So if you have diabetes,
Yes,
it is almost equal to having heart disease.
almost heart disease.
Almost.
So it's positively considered as in coronary artery disease risk equivalent, so that we better manage your blood pressure, better manage your
Glucose
lipids,
level,
and the
cholesterol.
glucose, everything, so that the outcomes are better in the longer run. Diabetes, we know this in colloquial terms is like high glucose. The seat of diabetes is insulin resistance. That's at the core of it. So the high insulin properly is not acting, the sugar is up, and that causes a lot of glucotoxicity everywhere. What happens in the endothelium? We talked about endothelium, the innermost lining. There is a lot of endothelial dysfunction. That's where it all starts. The inner lining of the blood vessel is a very sacred place for us cardiologists. It has to be healthy. So endothelium, when it is exposed to high sugar over a long period of time, again, it becomes more dysfunctional, means it's not able to relax as well as it should. Number one, it becomes very inflammatory. It becomes very sticky or prothrombotic, right? It becomes more vulnerable. There are a lot of reactive oxygen species in there. So a lot of things, all these multifactorial things can lead to early onset of atherosclerosis or plaque deposition.
I usually tell my patients that the more the number of sugar in the blood, the longer the sugar in the blood, the endothelium, the lining of the blood vessel, acts as a magnet. It just attracts all the blood clots slowly. The longer, the larger the clot, the more the heart attack.
So diabetics in Indian population, again, as I said, we are last from the 80s, from 1980s, we have surpassed everyone, and we have become the diabetes capital. Very, very, you can say, scary situation. Diet has changed from 80s. Lifestyle has changed. Stress level has increased. Economic growth is there, but at the cost of everything. So I think so before 80s, we didn't have much data for the Indian diabetics, but now it's humongous. Diabetes usually have multi-vessel. We actually talk about it. So more arteries are involved. If you talked about 3 arteries, the possibility of all the arteries being affected are very high.
Let me just
Yeah.
add a point.
Yeah.
So based on what we discussed before, based on how much blockage is there in how many blood vessels, the treatment option differ. We said that if the blockage is in only one blood vessel, you put a stent in. If it is in multiple blood vessels, we do bypass surgery. What you're telling me is diabetes is
Usually
prone for multiple blood vessels.
multi-vessel involvement.
So most likely bypass,
Most
very
probably
common.
And it actually gives better result as well in the longer run. So it's extensive disease, very small diffuse nature of disease. Calcification is more in diabetic patients, and the outcomes, I think so, with angioplasties would be slightly inferior in the given subset as compared to bypass. So whenever it's multivessel, calcific, bifurcating, diffuse long segment, we do a bypass. So diabetes usually, as I said, affects everything. It affects the nerves also. It affects your pain sensitive receptors as well. So the typical symptoms of pain may not be present always in diabetic patients.
This is what they call silent
headache. So what we experience, like the kind of exertional discomfort, pain, left arm, jaw pain, in otherwise non-diabetic patients, diabetes, since it mutes your pain sensation, reduces your pain sensation, they don't experience the classical pain, and what they are left with is just at times fatigability, slight breathlessness, not able to do activities that they were possibly able to do properly. So these are soft signs that you should be aware of. As a clinician, you should dig it out and you should ask from the patients, because not everyone will experience it. Most of my diabetic patients, especially the inferior or the basal wall myocardial infarctions, goes to a surgeon or a gastro first, because the pain is in the epigastrium, as you said,
the upper part of the stomach.
Severe pain rather than the. So they just come with epigastric discomfort, and ECG is ST elevations in the inferior lats. So that's a learning point. So that's the whole thing about silent. And usually you realize it after a couple of days or after 12 hours when the patient comes in, a lot of breathlessness, congestion in the lungs, the PP going down, ECG shows that already the attack has settled in for quite some time. The echo also shows the same.
So the learning point over here is diabetic patients should understand their body better.
Exactly.
Understand any change in symptoms. The things that you're doing before, if you're not able to do it now, please get it checked. I had a patient, it has been going on for a while, for a week. He was not feeling well that much, but he was just pushing along in his work and everything. In the evening, he told his family members that, I'm not feeling well. I don't want to eat anything. And then he just went to bed. In the morning, massive heart attack.
They don't wake up also at times.
They don't wake up sometimes.
So that's listening to your body, listening intently and carefully to any signs of symptoms, especially important in diabetic patients, because they don't have that classical what your teaching is, learning is, chest pain, heaviness.
I think even though it is a very bold statement, I think we can summarize this as any patient with diabetes, imagine that you have some kind of heart disease already.
You have to be treated aggressively and listen carefully. And listen to the signs, small niggles, signs, symptoms, and be careful. The easiest thing you can do, if you feel discomfort, even if it is atypical, get an EKG done. That's the easiest way to diagnose things. I think so. I tell most of my patients, you have any discomfort, the best thing is to get an ECG and sleep well if it's normal.
And if there's any symptom, don't wait too long. Get it evaluated. Yes, it is a bold statement, but the rationale behind that statement is to make an awareness that there is increased risk of heart disease among patients with diabetes.
Yes, 100% agree.
Does it matter about the A1C level if it is more than 8, 9?
Yeah, the higher the A1C level, the higher the
risk of heart disease.
Disease burden. Higher the disease burden. So it's very diffuse. Polyatherosclerosis, not necessarily heart, but the brain, kidneys, the peripheral vascular disease. You can see, a lot of problems. So every body system is involved. So it's polyatherosclerosis. So higher the A1C, direct correlation. Higher A1C, higher number of vascular beds involved, well controlled A1C, you can live normally. I think so. Better outcomes in the longer run.
Is it very aggressive in women?
Diabetes, especially heart disease in females, we don't have data per se which says diabetes in females behaves differently than males. But till the time menopause sets in, females are usually protected
With the estrogen.
Yes. But after menopause, the
Estrogen
risk,
goes down.
the risk is same. So that's something. The risk of diabetes, if it's diabetes, your risk is higher than a non-diabetic, irrespective of the sex.
Irrespective of gender.
Yes, irrespective of the gender. Yeah. So diabetics, be careful, be attentive, do your blood test regularly, get yourselves evaluated annually, and pay attention.
Let me ask you this. You see a patient with heart disease, not an acute heart attack patient. Outpatient, having heart disease, you say diabetes, you say, you better control your diabetes. 2 months, 3 months later, they come back. Is the blood sugar controlled by that time? I mean, what?
Patient having diabetes and
No. The question, let me rephrase it. So you see a diabetic patient, and then you have some kind of heart disease, and you are saying that it is absolutely important to control the blood sugar levels. How serious they take that suggestion and work on the blood sugar?
I think so. They take it pretty seriously. After diagnosing, I think so. They are pretty. As compared to, I told you, the
Blood pressure,
which is like a sideline cousin. People are slightly more aware and serious. Once they are not serious about getting diabetes per se, till the time diabetes sets in, they are not. But once the diabetes sets in, I think so, irrespective of the huge, communities and across India, they're pretty serious about controlling it, their sugars and maintaining them. They're pretty sure. They know what to do. The diet, again, the Indian diet is a different talk altogether, but they are particular about the diet at times. Most of the times, they are particular with the medications, and they try to control. I think so. Most of them, I would say 70-80% of the times, they actually do well in the follow-up.
What is the one thing that you wish your diabetic patient and listen and change?
I think so. Prevention is most important.
Preventing to get diabetes to start with.
Most important. Maintain that ideal body mass index or ideal weight. Very important. Pay attention to the diet. From the 30s, early 40s, you start paying. That's the time when most of the harakiri starts. So start paying attention more and more. So prevention is very important. After, say, unfortunately, because of the genetics or whatever, you get it. Still not everything is lost. You can reverse it if you have high body weight. If your A1C is like marginally high, like around 7.5, I have seen patients reducing their weight and getting that A1C normal.
Yes.
So that's a positive thing. So they do that, stick to medication, follow the physical activity, do that steps which are necessary, lose that weight, at least don't allow it to go out of bounds, eat well, eat mindfully. Very important. That mindfulness in eating, and like repeated it again, is very, very important.
What is mindful eating?
I think so. Paying attention, close attention to whatever
goes inside your mouth.
Inside your mouth is extremely important. And whatever you eat, do it with the absolute peace of mind. That's what I say. Choosing and enjoying it, but paying 100% attention. Nowadays, the culture is like you sit in front of the sofa and you gulp down whatever you want.
You look into the phone.
Phone here and eating here. So, I think so. Mindful eating is very, very important.
To be honest, I think that one little thing is something that everybody can do, rather than thinking about, okay, is it vegetarian diet, non-vegetarian diet? But more importantly, just with a regular simple thing that can reduce pretty much, like I would say, 10 to 20% of the problems. Because when you're mindful, you appreciate the taste better,
Yes,
you appreciate the flavors, and the likelihood of you being hungry is going to be low.
yes. So that's extremely important. So we talked about diet, choosing the proper diet, eating well, mindfully eating your diet in peace, taking time out for physical activities, reducing your weight, quitting smoking. Obviously, that goes without saying. That weight reduction, that diet, that physical activity alone for someone who was non-compliant before will reduce your A1C at least by 1.5. At least.
At least 1.5%. Yeah.
Yes, that's what I feel in the
In
clinical
your
practice.
experience,
Maybe guidelines would
Correct.
say around 0.5
Ah.
or something.
But in your practice,
But I think so because see, our subset is like non-compliant one. So either the A1C reduction would be much better in a non-compliant patient in already as compared to someone who's already slightly more understanding and compliant with this diet. So if you get a subset which is casual about eating, no physical activity, sleep and everything, I think so we reinforce the lifestyle modification, dietary modifications in them. The results are, I think so, almost 1.5% A1C reduction possible just to follow lifestyle.
you think lack of sleep causes heart attack?
I think so. Very, 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 very important. I think so. As the Dalai Lama says, sleep is the best form of meditation. Sleep is the best form of meditation. Why? Because it allows your body to reboot from inside. That's the like that period when you are actually the entire systems are at rest. The entire systems go a reboot, and you get re-energized. And without adequate sleep, so less of talk on again stress and sleep, again neglected factor. People boast, I just sleep for 4 hours. Longer run, I think so, makes a lot of difference. Take that time out, stay away from the gadgets after a set limit, maybe after 10 or whatever is needed, if you can. For someone like me who is always bound to phone is a different story, but take out that time if you can. Be away from gadgets. Try to sleep calmly, peacefully for at least minimum 6 to 7 hours. Longer run, because your body needs that rest. It needs that reboot.
So the next segment is the cholesterol. Okay. Based on the AHA recommendation, they say that we need to check the cholesterol levels starting from age 20 and then repeat every 5 years if it is normal. Age 20, it was like 20, 30 before, 25, now it is 20. So in your practice, let's say you check cholesterol levels like it's a normal patient.
Approximately 30 years is like the time most of the patients do come for a regular check.
Regular checkup, I
Yeah,
see.
after their set in career and all.
Correct.
So 20 students usually don't come to outpatient. So I won't be recommending. But yes, childhood obesity is a big topic. Again, I think so. Again, an epidemic which is brewing up. It's actually brewing up. Huge numbers. The next generation we will be focusing on a lot of childhood obesity. So I happen to check cholesterol, A1Cs.
American Association of Pediatrics is recommending lipid profile evaluation starting from age 2 if there is history of childhood obesity and also family history of any obesity. And they also recommend to check between 9 to 11 years of age. Again, based on. And people are actually, one very good thing about Indian communities, we are very family oriented. We're extremely family oriented to a point that a very drastic difference between the West and Indian community is there are 2 patients. Both are in ICU. Both are heart attack. Both are in, ventilators because of respiratory failure and everything. This patient, we go on round and we want to update about this white patient to a family member, how he's doing. I come out, I say, hey, family member of this patient, is there anybody there? Nobody is there. Okay, I go there and then there's an Indian patient. I review, I come back, I say family member of this Indian patient.
Delivered huge crowd which assembles. That's a truth. That happens every day. Every day to me.
It's a wonderful thing. It's a wonderful thing.
Social connect,
social
family
connect
is strong.
But that translates into feeding the kids a lot more than what they need.
Yeah. The love goes to the
food. Love goes to one more idli na.
Yeah.
One more dosa.
One more serving of rice.
One more serving.
That leads to
rice. So the parent should understand that, okay, so my kid on the growth chart or compared to other kids or slightly on the chubbier side, please go and check lipid profile and cholesterol levels as recommended by pediatrician. Because that is what is going to give you increased risk of heart disease at the age of 20 and
23. So that's an epidemic, huge epidemic brewing up, because we didn't find so much of childhood obesity, doing our 20 years back. Now, I think so. I have a few patients in teenage who are on statins and metformin and so on. So
wow. That brings the next question. So, of course, we know the good cholesterol, bad cholesterol.
Yes.
Everybody knows about LDL.
LDL, yeah.
And everybody knows about HDL.
HDL.
And it's always the opposite. Yes. LDL is high, HDL is low. It should be the other way around.
Right.
LDL is low, HDL is high. So, how people always get confused about this. I say LDL, L should be low. HDL,
H should be high.
H should be high.
Exactly.
Now there is this little thing again that they're talking about. It's called apolipoprotein little a.
Yeah, ApoA.
ApoA.
Right.
Is that something that you use practically over here in India?
So when we ask for a lipid profile, it's not to be taken in isolation again. So our lipid profile will have the important factors that I focus on: the primary target, secondary, tertiary, and so on. So we looked at the LDL, we look at the total cholesterol,
triglycerides.
We look at the triglycerides, we look at the HDL, we look at the ratios, LDL HDL ratios,
triglyceride HDL ratio,
triglyceride HDL ratios. We look at the ApoB, the ApoB, and we look at the ApoB, which is composite of all your bad particles together. It's like a gang. So all the LDL, triglyceride, chylomicrons will have that ApoB. So ApoB is a composite of all that. So higher ApoB is again a target which we want to minimize. ApoA on the other side represents the good.
Yes, ApoA should be high.
ApoA should be high. It represents the good cholesterol. So that is involved in the process of getting the bad cholesterol out back from the
blood vessel, exactly,
to the liver.
Wonderful.
Yeah. So
wonderful.
So the ApoB is something we target. So we are targeting that because the moment you can lower your LDL, triglyceride, chylomicrons, the ApoB tends to go down. Okay, and then there are ratios as well, ApoB and ApoA. But ultimately, most of the thing diet can control up to a certain extent, definitely. But if you're a cardiologist or a physician recommends, then maybe statins would be the best. And there are so many statins as well as no path-breaking achievements in the lipids nowadays. We have monoclonal antibodies coming up, the RNA-based therapy is coming up, which is like a vaccine, taken twice a year to control your LDL. So the coming era is going to be very interesting, very dynamic. But looking at the lipid profile, I will talk about the Indian dyslipidemia is different from the Western. So in Western counterparts, if you actually have a composite of maybe 100 reports here and 100 reports this side, the Indian dyslipidemic will have a slightly lower LDL as compared to the Western. That is the only good thing. Our LDLR don't tend to be like 200 plus or 180 plus, around 160, 170. But our dyslipidemia, the Indian subcontinent dyslipidemia, is characterized by very low HDL. Yeah. Our HDL is very low.
So normal is around 40, 50.
For females, it should be more than around 45 plus.
45 plus.
And males, it should be more than 40 plus. Ideally,
What do you usually see
in
in HDL numbers?
HDL number, 45, 40.
When you say low, how low it is usually?
Yeah. So, Indian dyslipidemia, I say moderately high LDL, very low HDL. I have seen 19, 20, 15.
15.
Yeah. Lack of physical activity. No proper diet. We can come about like therapies to how to improve your HDL. But apart from moderately high LDL and very low HDL, our triglycerides are sky high.
Sky high.
It's not unusual. It's not unusual to find triglycerides in the range of 1000, 1200, 1400 as it's bad.
I have been practicing for 8 years now. 1200 triglycerides I've seen only like once in 2 years.
Here we find 800, 700, very common.
Very common. 800.
Triglycerides. Again, focus, as you said, the Chinese basque. So, ordering from all these portals and the kind of diet is...
Uber Eats, Swiggy, Zomato.
It causes huge problem. This is our typical dyslipidemia. Moderate to moderate high LDL. As compared to Western counterparts, our LDL is not as high. But that is,
I'll tell you a very important point. I think this is a wonderful discussion over here where people in West over there, they keep on focusing on the LDL where they say, it should be less than 100, less than 70. If you keep on doing that, they'll say LDL should be 0.
Yeah. Right. Yeah.
But in Indian community, I think the one thing that we should really look at is exactly what you said, is triglyceride HDL ratio.
Very high.
Triglyceride is very high, HDL is low, which means the ratio was high.
Very spiked.
Very spiked. If it is more than 4, increased risk of heart disease. It should be less than 2.
Our triglycerides are sky high.
Mainly because of the carb-based diet.
Excellent. So much of carbs. 80 to 90% of the Indian diet will have carbs. Food portions. Less protein and fats. So, I think somehow that ratio is totally skewed for spiking the triglycerides.
Will you agree that high carb diet increases the triglycerides, increases the atherosclerotic burden leading to heart disease?
Right. I think so. We in India, especially the Lipid Association of India, we have a different body, focuses a lot on triglycerides as compared to Western counterparts who feel the primary target is LDL, second is probably HDL, triglyceride is again a forgotten cousin. Nobody bothers about triglyceride. They say it's an innocent bystander. Yeah. But we don't agree here because our triglyceride is very inflammatory. It leads to a lot of atherosclerotic burden, and higher the triglycerides remain. Say, I'm not very concerned about something like 180, 200 types, but this 700, 800, you have to treat aggressively. If you can't, obviously the inflammation and the atherosclerosis worsen.
What are you talking about? Usually, we get to see triglycerides of 800,000 only in a case of
pancreatitis. Yes. Here.
This is normal you're talking about.
See, you take a serum sample. If you happen to collect a vial of blood, and let the blood settle. In a patient with hypertriglyceridemia, we usually have been taught the serum is not clear at all.
Correct.
It's milky,
it's cloudy,
almost.
milky.
Yeah. So that's the kind of triglyceridemia we are dealing with.
I mean, this is so fascinating, but I'm just going to summarize it for the audience. Is that what Dr. Anup is talking about is when you take a blood sample, you look at the test tube, usually triglyceride is very pale. You can see through a little bit. But when the triglyceride is very high, it looks milky white.
Almost milky. And that calls for attention. That calls for attention. So in West, it might be a tertiary target. In Indian, it's our primary target. That is the reason triglyceride lowering therapies are important. I think so are important to prevent atherosclerosis burden in the future. And we target it.
I know exactly what triglyceride lowering therapy is. Decreasing the amount of carbs.
Exactly. That's the focus. The first thing I tell my patient, you reduce the carb load. The question is like in Hindi, he says, चावल नहीं खाएंगे, चपाती नहीं खाएंगे तो खाएंगे क्या? That's the way in which question is always framed. You have to give them options, right? You have to tell them there are many things. You have to go beyond. You have it as a small portion. You have the first course or whatever it is. You start with salad or some protein or dal or sprout. Have inculcate, and then we are left with something. You have that portion of, reduce the portion of chapati and rice, I guess. But I guess our rice are like huge and heaps of rice, and that creates a huge spike. And it's important because everything is going to reflect in the atherosclerosis.
So that's why I say, in South India, we always have this banana leaf wedding where, they keep on serving rice on the side, right? So I said, we should turn it. It's called reverse banana leaf, where you make all the vegetables on this side and you keep rice on the other side. So that first you eat the vegetables
and
fiber,
then
you feel full.
Yeah.
The second thing is it is too difficult to take the rice.
Reach out. That's a good plan. No, I think so. We all need to work and we need to educate. And that's very, very important.
That is what you're doing right now.
Yes.
You're doing exactly right now.
Right.
Hopefully people watching this, you talking to one patient in your office, it's exactly you're talking to like thousands of people over here.
Yeah. So again, that concept of in India, hardcore vegetarian, hardcore non-vegetarian, it's a very different ballgame. One feels we are doing the excellent thing by being a vegetarian. One feels we are also doing the good thing by just eating protein. But ultimately, balance is important. In India, unfortunately, despite it being like almost 60%, 50% vegetarian country, it's very different from the Western vegetarian option. It's actually...
I know the Indian vegetarian. Okay, few people are very good, but most of them, Indian vegetarians, laddu, jalebi, jangri.
Yeah, but they keep on then parking on that. It's not good. Someone actually coined that term. I don't know whether it's right, but contaminated vegetarianism. I think so. I don't know, but I may not agree. But when I looked into it, and then we tend to agree for the sake of being totally vegetarian, they actually inculcate a lot of other stuff which may not be.
Part of vegetarian, of course. The problem is people think I'm a vegetarian, so I'm healthy.
Yeah, that's a misconception.
Because Indian vegetarian diet predominantly contains a lot of ultra-processed foods.
That's
a lot.
So need a balance, right?
I'm not eating chicken. I'm not eating beef. I'm not eating... You better eat that. But rather than avoiding the chips.
That's
cookies, biscuits.
Eating chips and cookies or whatever, bars for the sake of...
Correct.
No, that's not good. So that actually is I try to balance it. Balance is important. And I think so once you reduce the carb load, your triglycerides will get better. Your HDL. HDL is again a different beast altogether. The dietary... therapies, very difficult.
One thing people can do, usually exercise is the only thing that increases HDL. Or you are genetically gifted where HDL is more than 15. But sometimes omega-3 fatty acids.
Again, the fishes,
salmon, tilapia.
Avocado is there. Walnuts are there. Indian patient, most of the times we do avocado. I think so. Again, tier 1 cities only. Not still penetrated in the
tier 2, tier 3.
Yeah. But flaxseed, I tell them at least try flaxseeds.
You think flaxseed helps in heart disease?
Yeah, I think so. Slightly, whatever the data is, it increases the HDL. Walnuts are there. Some almonds, oily fishes, avocados. So I think so. It's but apart from that, I think so. Physical activity, very important. And HDL at times is very resistant despite doing this, and you don't have therapies.
So when you do all this, you increase the denominator of the triglyceride HDL ratio, which means the ratio will come down.
But if you can't, despite everything, despite modifying the diet, physical activity, most of the times it's genetic as well. You're not genetically blessed, and the HDL tends to be resistantly low. What you can do is to try to shrink the numerator as much as you can. When the LDL HDL ratio is there, so you have therapies to reduce LDL. When you have the triglyceride HDL ratio, try to reduce the triglyceride. So the ratio has to be.
Do you hear this often that, doctor, this is familial, it's hereditary. My cholesterol level is not from me, it's from my family. I always say the joke that, it is not that cholesterol runs in your family.
Because
the problem is no one runs in
the family. That's so true. So
that's a running joke in my practice. How important is hereditary? How can you say, is it true that they can say, hey, cholesterol is due to my family problems?
at times it's we have definitely the genetic variants of high cholesterol, the familial variety, wherein the receptors, the LDL receptors are absent, leads to familial hypercholesterolemias and xanthomas and xanthelasmas, something below the eyes.
What is xanthoma?
Xanthoma is like the cholesterol or the lipid deposition which you actually see below the eyes,
Below the eyes.
clinically or on the
like a small
elbows.
bumps.
Yeah, bumps, the cholesterol
Mainly
bumps.
in the elbows.
Below the eyes,
Below the
around
eyes.
the eyes.
I've seen a patient over here. I will not. This is a wonderful example I never forget. A patient comes in, fit like a beast. He was completely numb, but he has a small little bump, and he was thought he has been there since for a long time. Cholesterol levels, triglyceride 500, hypertriglyceridemia.
Hypertriglyceridemia. You need to treat it. So xanthomas.
The point I was trying to make was the percentage of patients whose cholesterol level is high truly because of genetics reasons is very low.
It's low. It's low, but it's there.
Is there, correct. Agreed, is there.
Some no risk factors, no dietary, lifestyle good, still they have high LDL, then we have to think about genetic or the LDL receptors on the liver not being very in adequate numbers to take up that LDL from periphery. So your LDL will be high. In such patients, if you observe it and regularly follow up, and if the LDL tends to be high despite whatever you do, lifestyle modification, I think so we prescribe statins for such patients.
Yeah, that's a beautiful question, beautiful segue to the last segment about statin. So when we prescribe statin, the first response that I get, especially from a patient from Indian community, is I don't want to take it.
Yeah.
I don't want to take it. I am going to try lifestyle, and I don't be on any medications at all. Question to you is, in your practice, what is the percentage of patients who are able to decrease their cholesterol levels with lifestyle changes in 3 months? Just a percentage, probably.
Less.
25%?
20%.
25%. So you see 100 people, 25 people will be able to do. Remaining 75 people, either they fall off the wagon, they're not able to do, they forget about it.
I think so. It's important. As I said, if you have a diabetic patient, your LDL, we know, has to be below 100, ideally below 70. That absolute number. Non-diabetic, again, with some family history, we want it to be less than 130, ideally. The whole purpose of having the LDL in control is to prevent end organ damage and better cardiovascular outcomes in the longer run. So we are not giving statins to prevent heart attack tomorrow or day after, but in the longer run. We are looking at this. So this is something that needs to be fed into the minds, educated. I would say many of my close friends also don't take it, despite. So there is a resistance to take statins. 2 or 3 things. Again, silent, doesn't bother. Number 2 is statins cause diabetes. That's something which was so much on the high dose at times would lead to small spike in A1C levels, but the benefit of LDL reduction is much, much, much higher as compared to whatever the small spike. So it's not again very proven, but yes, it could be with high dose statins, the kind of statins dose that we use. But we see a lot of patients, 80 milligram of atorvastatin or rosuvastatin, 40 milligrams. A spike is small, but it's there at times. But not everyone gets it. But that's again a sort of a deterrent for them to start taking it silent, and something is like, yeah, they find solace. It causes diabetes, let it be. So uh, third is like, I don't want to be labeled as take. So the taboo factor, 2 or 3 things always are there in a picture, which inertia causes a lot of inertia to the whatever I won't say patients, but OPD guys to take up statins.
Wonderful.
But we have to educate. Education is at the heart. Again, we look at and so many data and like over meta-analysis.
Yeah. I mean,
30,
usage
40
of
years.
statin is like, it's beaten to death.
Yeah, and I think so. That is beneficial. I think so. Everyone who needs it should take it properly.
So I'm just going to summarize the key takeaways from our conversation. So number one, people should not be concerned about angioplasty, bypass surgery. Yes, it sounds aggressive, sounds invasive, but if you need it, it is absolutely needed. Okay, it is okay to proceed further because the benefits outweighs the risk. And number two, we have talked about all the treatment options for heart disease, and it is very clear that it is better that you don't get the heart disease to start with.
Yes.
Prevention is always better.
Always better.
You told me that.
Yes.
Third one is hypertension is a silent killer. And as much as we are focusing attention on diabetes, we are not focusing on hypertension. And you talked about the 24-hour ambulatory blood pressure and everything. And it is absolutely critical to decrease the blood pressure. And we talked beautifully about the pathophysiology of how hypertension, endothelial dysfunction causing heart disease. And diabetes, we went deep. We make sure that A1C level comes down. And a silent heart attack. Very critical because the nerve supply is impaired, so you will not feel the pain. And the last one, we talked about the lipids and statin. If somebody prescribes you, please take it.
Please take it. Very
Please
important.
take it. Maybe if you really don't want to take it, you can try for 3 months. If you're not able to decrease in 3 months,
Better take it.
better take it.
Better take it. Whatever it is, the number should be correct. You should target the numbers. As in the corporate world, the numbers should be reached.
You meet the demand.
So that I tell them, do whatever you want. Make sure it goes below this. If it's not going below that, I will give you medication and you take it. You don't have a choice.
Wonderful. It was a wonderful, wonderful discussion. It was absolutely amazing. I'm sure my audience must have learned a lot from you. Thank you again so much for your time.
Thank you so much. Pleasure being here.
I had so much fun in this episode discussing with Dr. Anup Taksande. I'm sure you learned a lot as well. Again, I don't want you to just move on. Think about what you learned during the podcast. I want you to write down in the comment section so that the writing actually registers the fact in your mind so that you will actually implement it and not just use this as a bystanding video and just a scrolling thing. I don't want you to do that. Okay. So I want you to learn at least 1 or 2 points and hopefully you will be implementing that not only to yourself but also to your family members so that together we can grow better both physically and also mentally. Thank you for your continued support. Please consider subscribing to my channel Gut Feeling with Dr. Pal Clips and Gut Feeling with Dr. Pal Shorts, 2 separate channels with condensed clips from 8 to 10 minutes and sometimes 1 minute shorts and reels of this clip from the longer 1 hour podcast highlighting the salient features. So if you're a person who wants to listen to the audio format, maybe while you're commuting or while you're driving, we are available in Spotify as well. Please check out the link Gut Feeling with Dr. Pal in Spotify as well. As usual, thank you so much for your continued support. Remember, one belly at a time. It is absolutely important. I'll see you in the next video.